Hello. Thank you for joining our webinar today. My name is Catherine Mezerkevich. I am a patient advocate for Pheo. In 2017, after a few years of symptoms, I was diagnosed with head and neck paragangliomas. I had multiple bilateral tumors, and because of the presentation, they thought that maybe there was a genetic component to it. So I was tested. I have an SDHB gene defect. I ended up having 3 surgeries and a series of radiation treatments for the tumors, and I am now followed up with on a yearly basis. I'm here today with Samantha Greenberg, who is a genetic counselor, who I'll introduce in a moment. But first, I just wanted to take a second to say thank you. This program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma and paraganglioma, their families and medical professionals through advocacy, education, and a global community of support, while helping to advance research that accelerates treatments and cures. I want to take a second to say a special thank you to Progenics for making this webinar series possible through an educational grant. I wanted to remind you to please sign up for our e-news and follow us in social media. We are Pheo. This webinar is the second of a 2-part series on genetics. The first episode is available for viewing at pheopera.org. Also wanted to remind you to please join us for our monthly online patient hangouts. They're on Zoom. They're the first Tuesday of the month at 4:30 Pacific or 7:30 Eastern time. Each meeting, there's a different theme to discuss. The link to register will be in the chat function. Our agenda for today will be that Samantha is going to do a presentation. Then we will begin taking a Q&A. Some of these questions have already been submitted, and you can also ask questions that will be submitted in the chat function. Many people will ask variations of the same question, so please, we ask that you listen carefully for questions that are similar to yours. And also, could you please keep from posting case-specific questions and kind of make them of more of a generic question. Keep in mind that Samantha is not able to give any medical advice. Her expertise is in genetic counseling. Okay. The information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and medical team, because they have a more in-depth knowledge of your particular medical history and your current situation. All right, and with that, I'd like to present Samantha Greenberg, who is a genetic counselor at the Huntsman Center for Cancer Institute. She received her master's from the University of Michigan for genetic counseling and public health after teaching 7th grade in Tulsa, Oklahoma. Samantha oversees the SDHX Paraganglioma Clinic and high-risk prostate clinic at HCI alongside a multidisciplinary team. Her research and interests center around prostate cancer, paragangliomas, pheochromocytoma, and education, where she serves as a faculty member with the University of Utah Genetic Counseling Program.
Okay. Great. Thank you all so much, and to Pheo Alliance for having me back for the second part of this presentation. We're going to be talking today about addressing family dynamics associated with a genetic condition. As Catherine mentioned, this is one of a 2-part series. In the first part, we talked about having a mutation and now what, really walking through what that means for someone and their family and common challenges to a new diagnosis. Today, we're going to talk about how we address this with family and kind of walk through these bullet points. And for those that joined us in November, I just want to highlight that that was a little bit more kind of information focused. And today, what I hope to do is walk us through an exercise and really think about how you address this with your family. There is no cookie cutter solution to this. And what I'll try to do today is provide a number of solutions and give you an opportunity to think about what might work best for you and some of the challenges that many of our patients encounter. So I start with my first kind of slide just to make sure everyone's on the same page. For those that are new to Pheo, these are tumors that arise from neuroendocrine tissue along the base of the skull to the pelvis. and also in the adrenal medulla, known as a pheochromocytoma. On the left, you can see the green chain that represents the parasympathetic and sympathetic nervous system, which is where these tumors can arise. And that middle picture shows in the red all of the locations in the kind of chest and abdomen pelvis area that paragangliomas can develop. And on the right, also areas where we can see head and neck tumors like carotid body and glomus tumors, among others. So you may be wondering why we talk so much about genetics when we're thinking about Pheopara. And the reason for that is because we know that approximately 40% of these tumors are hereditary. And if you have more questions about the condition specifically, I'd encourage you to check out Dr. Lauren Fishbein's webinar on the genetics of Pheopara. She does an incredible job of walking through the conditions that we see here on the right. And I show the time frame just to show that our knowledge as far as Pheopara genetics is still relatively new in the last few decades. And for a number of conversations today, I will be focusing on the SDH genes, which are circled here, which are the genes that are more commonly seen with the paragangliomas that occur outside of the adrenal gland. So I want to just launch in and actually start with an exercise and encourage you to take a second to look at this wheel and think about where you're at in terms of your genetic diagnosis. You may have just recently learned that you had a mutation. You may now know for many years that you have one, that you've had one. But if you take a look at that inner circle, I'd encourage you to find a few words on here that apply to you. If you're feeling kind of peaceful or scared or mad or powerful, right? And then you can kind of move to the outer edges of this circle to identify kind of more nuanced versions of these emotions. For instance, if you're feeling peaceful about your diagnosis, is that a content type of peaceful? Is it trusting? What does that really look like? And potentially go to the even outside circle to say to yourself, okay, how am I feeling after this genetic diagnosis? Personally, as a genetic counselor, my goal is to help patients feel, in that kind of peaceful category, right? Thinking potentially thankful that we know that somebody has an increased risk so that we can proactive and screen in advance. That's some patients, not everyone. Helping people feel confident that we can be proactive and screen in advance to ensure that that things are working. And then in addition, really making sure that we've kind of gotten to a positive place. On the other hand, I know that many patients come in and they have experiences. Yep. Is there feedback? Sorry, I'm just going to pause real quick. There may be feedback for those that are listening. Okay, I'm being told we are good to go. So the other kind of boxes that I've highlighted are areas that patients may be feeling at the start of a diagnosis. There may be feelings of guilt or concern about passing it along to family, surprise. Sometimes people find out they have a mutation and there's no history of parapheo in their family. They may also feel overwhelmed in this process. And all of these are totally normal feelings to have. And so before we think about talking about this with family, I want to just stop and kind of encourage you to ask yourself, am I ready to address this with family? I'm reminded often of the flight attendant who says you have to put your mask on before you can help others, right? You can't pour from an empty cup. And so ensuring that you're in a place to address this with family is one place to start. So I want to just highlight, when we think about the grief cycle, we often think about losing a person, but I think it's important to note that when someone has a new genetic diagnosis, this is a little bit of a loss or a deviation from normal. And we have to go through that grief process before we can get back to the next normal or whatever our new normal is going to look like. And so we often go through that surprise feeling, confusion, frustration. We can feel overwhelmed, right? Think about those words on the wheel and see if they might match up to places where you are here on this cycle. As we process through, right, we start to reach out to others, we look to find meaning, and we ultimately get back to our next normal, right? And determine what that new normal may be. And the one thing I don't love about this graphic is it appears to be not exactly linear, but maybe not as representative as many of our experiences are. For instance, we normally think about how we want grief to work, right? This straight line process, and I move through each of the steps. But we know that grief can be a process. And so one day we could be feeling like we're ready to move forward. And then the next day we're feeling overwhelmed or a little bit helpless in this process. And our role as your care team is to help move through this and to identify what that next normal is so that a genetic diagnosis isn't disruptive. It's something we're able to move through and move on to what the new normal looks like. I want to just share a quick example to highlight that this process is common. And this is a study that was done, recently published in Health Psychology, of about 100 patients with SDH mutations. They completed surveys regarding distress, uncertainty, and their experience. And they found that people had higher levels of worry if individuals had children. They attributed this to potentially worrying about if children would get Pheo, potential guilt about passing the mutation on to children. People reported that genetic testing generally made it easier to cope with the disease, oftentimes because they were able to be proactive and move forward. And distress was highest in those with tumors and who had children, often attributed to the fact that they were likely balancing lots of different aspects of this new genetic change or finding. And I share this to share that you're not alone. And as we think about, the fact that we know many people may be processing through a new genetic diagnosis, I'd encourage you to think about how you've handled difficult news in the past or when something has been life-altering and how you coped. I think that this is where we really need to start when we think about, okay, I have a genetic diagnosis. How do I move forward in getting ready to talk with family? When I think about something life-altering, oftentimes people will say, my life's been pretty standard for the last few years. And I'd encourage everybody, I don't know anybody that might have said that about 2020, but COVID is one example to use to think about how you coped. What was life like in March, April, May? How did you settle into that kind of current version of normal? And leverage those to think about how you can process a new genetic diagnosis. Strategies like asking for support, meditating, exercising, self-care, those are all great strategies. For me personally, when the mountain is starting to feel insurmountable or like it's too hard to start climbing, I often turn that into bite-sized kind of processes so that instead of climbing one huge mountain, I'm climbing a lot of little hills. Out here in Utah, we ski all the time, and we have a common phrase as people are learning to ski and they progress up in their difficulty, that any hard run is a green or the easier mountain or kind of the easier runs if you turn enough. And I think that this is a perfect example that one strategy could be creating lots of turns or a bite-sized list of how to go through this rather than trying to tackle the whole mountain at once. So I want to share a little bit about where we're trying to head when we're thinking about processing a genetic diagnosis. And I once heard this analogy that I think is an extraordinary one, where our goal is to help you watch the piece of trash go by in the stream. And for the purposes of this analogy, I'm going to compare the genetic diagnosis to a piece of trash, though I don't necessarily believe that. I believe genetic diagnoses can be helpful so that we can screen and be proactive. But I do think it's important to note that for the sake of this analogy, that's the comparison. So I want everybody to picture themselves, you're standing over a bridge, you're looking at a stream, and you're watching everything pass by. You might see a twig, you might see kind of marine life, you might see kind of different wave processes coming through, and ultimately then you see a piece of trash. And unlike the other things that you've watched pass through, here you're actually going to watch that piece of trash and go take it out of the stream. And you're going to stare at it and you're going to look at it and say, I wonder where it came from, and I wonder where it's going, and I wonder who it's going to be and how it got in this place. And we overanalyze this one thing when in reality, there's lots of items happening in the stream, right? We're more than our genetic diagnosis. But for the moment, we're really kind of focused on this new piece of news. And over time, our goal is to help move away from that so that the piece of trash becomes an item that you see go through the stream, but we don't necessarily see, worry about it like we don't worry about the other things. This piece of trash or this genetic diagnosis becomes a part of our life. It's just like everything else. It's not our whole identity. It's just one of the things that makes us who we are. So I want to highlight a few strategies to help get to that place and encourage you to really process through this analogy, right? When I think about my genetic diagnosis, how do I address that compared to other things? Am I standing on top of the bridge, watching everything go through the stream? Or am I focusing on one or two things in that stream? And I need to get back to kind of that bigger picture. So a few items, I highly encourage you to reach out to your provider. If you are struggling to adjust to the news, you are having uncertainty, struggling with your care and talking with family, that's part of what we're here for. And I think it's really important to be clear about your needs. What will help you? Some patients say to me, it's going to be really helpful for me to start screening now. That way, I'll get the baseline underway, I'll start that new normal, and once I start it, I'll be able to adjust. And some people say, I'm just not ready. I really need to take a few months, not years, but by taking time, right? Take a little bit of time to process, and then I'll be ready to get things started. And ask yourself if someone else might help. A psychologist or a therapist could be really beneficial in helping us get to that place that, again, having a genetic diagnosis is just a small part of who you are. It's not the whole identity. And I know that Catherine talked about these, but Pheo Para Alliance is an incredible resource. Seeing if there are people in the area, your area, you could meet up with, attending the monthly calls, really think about how you process challenging news and whether or not this would be beneficial. So I'm going to shift and talk a little bit about family. I've shared this before, but I just want to get us all on the same page. So when we think about mutations in regard to other family, we know each person has 2 copies of each gene. And all you need is a mutation in one of those copies to have an increased risk for developing paragangliomas. Doesn't mean you will develop one, just means that one copy of that gene doesn't have a mutation and one copy does. We consider this autosomal dominant inheritance in that first-degree relatives would then have a 50-50 chance of inheriting that genetic change, right? Because they could either inherit the copy with a mutation or the copy without a mutation. There are exceptions to this rule. I would refer you back to part 1 where we talk a little bit more about them. But to note, right, if in like the scenario of SDHD, if somebody has a mutation, then there's still a 50-50 chance to have that mutation in that copy of their gene, but the tumor risk only increases if that genetic change came from dad. But genetic testing is still warranted. So we've talked a little bit about how to get yourself ready. And now the question is, how do we talk to family? And I'm going to use some of these strategies and encourage you to think about what works for you. So one option would be to make a list. Who do I need to tell about this? And you're going to want to start with your first-degree relatives, children, siblings, parents, and think about where they are and how we might contact them. Is it all at once? Is it in one-on-one phone calls? Do I have a weekly Zoom call? What does that look like? It's important to note that if any of those family members are deceased, you may want to include their next of kin. So for instance, if I have a brother who's passed, but they have children, their children would be nieces and nephews, the ones I might want to reach out to as a part of my list. And if you'd asked me back in the beginning of 2020 when I would see my family, I'd also encourage you to make a list. Do you guys have family reunions? Do you do weekly dinners? What does your communication really look like? Now in the COVID era, this may look like virtual family calls. Potentially they're a part of your COVID bubble. You do big calls over the holidays. Identify when the best time is to talk to people. Again, individually or in a group, in chunks of groups. Is it sending an email? What is best for you to be able to talk with your family? And I think that it's really important to think about what your family needs to know. So oftentimes we're taking in a ton of information, and I wanted to just boil this down into a few key points. The first key point, right, there was a mutation identified in this gene, and I'm at increased risk for these tumors. There's a 50-50 chance that you, as my first-degree relatives, could also have the same genetic change, and be at increased risk for tumors. And lastly, that there's screening options, right? We're not just learning this information for the sake of knowing, we're learning it so that we can catch tumors early prior to symptoms. So I have a lot of people that we've walked through this whole process and they call me or they email me and they say, Samantha, I'm nervous. How do I prepare for this? I don't know how it's going to go. And I encourage them to prepare for it just like they do any other important talk. So think about a time. Have you, when you've public spoke, when you have had tough conversations with family or friends, if you had a concern with a partner, if you and your boss had to have a challenging conversation, how have you prepared for those? And every person's going to be different. I often use my family as an example. We all use very different strategies when we're preparing for conversations. I walk through things and I practice out loud. And for really big presentations, I have someone sit with me and walk through it as well. My mother writes out kind of key bullet points that she can't miss. And she knows that as long as she has those, she can kind of go with the flow and walk through what she needs to say. So everybody's really different, but I think it's important to think about what works for you. And the examples I'm giving may be different for me than for you. And that's kind of the point of this, is just to generate ideas. So now we've prepared, we're in the middle of the conversation, we're going through our key points. What can I expect? I think it's really natural to expect family members to have questions, to want to get tested and want to know how. And I also think it's important to know that this may start their potential grief process or their worry or concern. And so they may have emotions, if we go back to that feelings wheel, that are how you felt in the very beginning. So in order to prepare for those, we want to think about working with the person who identified your mutation. If your family isn't local to where you are, there is a findageneticcounselor.com website that they can put in a zip code. And then the specialty we typically use is cancer, and find somebody within a radius of them. Currently, in the middle of COVID, there are lots of telehealth options. And I think the other thing is really to think about what it means to share your experience. You've been through this. You've processed emotions. And I have to believe, even if there's been positive emotions from the start, there's been moments in time that you've had a variety of emotions, and walking through how you've processed it can really help your family members understand that this is normal for them to have questions and potentially have emotions with this. I'm going to start to incorporate some aspects about children. I know we have a lot of questions about that, both from November and previously submitted. I think we have to also think about how we help kids understand what's happening. And we have to use the experiences that they know. Have they watched you have symptoms from a tumor or watched somebody go through a treatment? You might ask them, talk with them about, we go to the doctor to make sure we're healthy. So we want to test to see if we need to go to a second doctor each year to make sure that we're healthy. Well, the thing that's unique about this is you're not just going to see another doctor, right? Your family might be going to go see another doctor. And so really making this a group opportunity. On the other hand, I want to highlight that it's so imperative to be age appropriate. The example I just gave will not work for teenagers or for people who may have watched you go through it at an older age, and even they're kind of in their late teens, but they were a preteen when they watched someone in the family have a tumor diagnosis. Sometimes I describe Pheopara to kids, and I'll ask them if they can picture what it would feel like to have a bear chasing you, or that adrenaline rush. And this is a very bare bones. This obviously does not highlight all of the symptoms associated with Pheopara, but I'll ask them to think about that and explain and have them imagine what it might feel like to feel like a bear is chasing you, but you're lying down to go to sleep. Or you feel like a bear is chasing you in the middle of the saddest part of a movie. And to describe that sometimes people have these growths in their body that cause them to feel that way. And so our goal is to identify if you could potentially have those, so that we can identify them and take them out before we ever have any of those kind of signs or symptoms. You may also adjust based on how they've coped if you've had a tumor. You may be able to use the same terminology from that person's diagnosis and to explain that the goal isn't to have symptoms and then identify a tumor, right? We want to keep you healthy. Our goal is to make sure that that doesn't happen to you. If a family member had a tumor before a genetic diagnosis, our goal is to find a tumor knowing there's a genetic diagnosis before symptoms occur to optimize quality of life. And then when we talk about screening, I'll give a few more examples, but we'll talk about taking extra pictures of the body to make sure you're staying healthy. So I want to walk through a few common questions that arise when we're talking about testing family. The first two kind of are a little bit related, where we talk about, okay, a family member doesn't want to get tested or they're having health issues that could be Pheo-Para, but they're in denial. What can I do? And I have to kind of just preface and say that my advice here is not going to feel great, because my advice is that we have to get to a point of kind of realizing that we've done the best we can. I think you can ask yourself, okay, did I walk through the key points? Have I given my family the information that they need? Is there anything else that I can do as far as information giving and creating access? And other than that, it's not within our locus of control. We see quite often that family members decide they don't want to get tested or they aren't ready for this information. And that's a really personal decision that can be hard when you've had that experience, but is one we need to allow family to have and be here as a resource. I also know there have been some questions about variants of uncertain significance. We do talk a little bit more about this in part 1, but I'll just highlight that a variant of uncertain significance is where we find a genetic change, and it's unknown if this change puts people at increased risk for Pheo-Para or not. Now, most of the time we have changes in our body that just make us unique genetically to everybody around us, and they don't necessarily impact our health. And that's been shown in the research, where over 90% of these uncertain results have later been classified to negative. As a result, we consider these uncertain results innocent until proven guilty, and we treat them as a negative test result. In regard to family members, that means that we won't necessarily screen or test other family, because again, most of the time these uncertain results become negative. So now you've told your family, let's move on to the screening portion, or to the testing processes. So if family members are interested in genetic testing, it's imperative that they have a copy of your genetic test report. Whoever orders that genetic test is going to need a copy of your report in order to help that testing get set up. If family's local, use your care team, or even if they're not local, to find a place to get them set up for their visits. Genetic testing is typically a blood or saliva sample. It's often covered by insurance, but there are some labs that offer free family testing within a few months. And so even though we're not super concerned about insurance coverage, because it is often covered, this may be a benefit. We find when people hear the word free within a certain amount of time, it typically can be a little bit more of a kind of jump start to starting that testing process. And so knowing if you have that, especially if you've been tested recently, can be helpful. So I want to just highlight really briefly, at a genetic counseling visit, our role is to help identify family members' goals for the visit, walk through their medical and family history, discuss their risk, genetic testing, how that genetic testing can impact them, and make a plan for follow-up. And if your family members have questions about that process, there's a website called aboutgeneticcounselors.com that can help, has a number of different videos to just walk through what to expect at a genetic counseling visit. So now we've walked through, how do I talk to them about needing testing? Now they've gotten tested. What happens when family members test positive? And we recommend that family members undergo screening regardless of if they've had Pheo-Para before, and to find a team with that experience and expertise that can be really beneficial. Part of the reason that the Pheo-Para Alliance has launched their kind of Centers of Excellence program is to help find those resources. But if you need help finding one near you, I encourage you to just call your local genetics clinic and ask who they refer patients to find your care team. As we noted, screening changes when someone has a genetic mutation. Here on the top, you'll see examples when someone has a mutation in the SDH genes. In the bottom, if someone has von Hippel-Lindau. And it's important to note that these differ by condition and individual history. In addition, you'll note that the ages to begin can be as early as, younger than 5, but for a lot of people, we're starting something between the ages of 5 to 10. And this leads me to talk a little bit about screening for children. I think it's important, as we've noted before, to really think about where they're at developmentally and where they're at in the process. 5 is very different from 15. When I'm working with people about to undergo their first screen, we often talk about taking pictures of their bodies. And then what I do is, whatever family member that's also tested positive is with them, we pull up their scans and we walk through it and we say, look, that's the brain and the lungs and the heart. And we help children identify, just like they do in school and other places, apply what they've learned about the human body to their family member scans to understand what this is going to look like for them. There are apps and websites and printouts, you name it, to help children prepare for these scans. And I want to just show you 2 screenshots from one of the videos about getting an MRI. Here you can see 2 aspects. On the right, this is what a child can expect when they go into the MRI. They get to see the machine, they get to watch the process occur. And then on the left, they get to see what their doctor is seeing on the backside. And again, helping children say, there's my brain, there's my this organ, are ways to help them relate to things that they're learning in their everyday life. I want to highlight the benefit of child life specialists. Oops, sorry. The benefit of child life specialists. So these are kind of experts who work with the child's treatment team to meet the emotional, developmental, cultural needs, and they do a number of roles, but they're very helpful on the screening day themselves by helping the child understand the medical procedure, helping them encourage cooperation, and really easing that concern that they may have. So we've walked through the process of screening with children, but as we all know, our kids will grow up and they'll become adults. And the question becomes, how do we transition that management from child to adult? Technically, when someone turns 18, they're an adult, but that may not be the right time for every child. The transition process often takes many years, and it's important for families to make individual decisions on the right time to begin. This can be as early as kind of the end of the preteens, and for some, it's kind of later until they're in college and starting that process. And there's lots of aspects of screening when we think about transitioning. It's not just scheduling and keeping track. It's also, is your child on the phone when the doctor is calling with the imaging results? It's who answers the questions when the doctor's asking how you're doing. I also think it's important to note that for some tumors, like Pheo's, sometimes after the child has hit puberty, it may make more sense for them to be with an adult specialist, depending on a patient's certain scenario. And so those kids are going to start a little bit of that transition earlier because they're moving to new doctors in this process. Again, these may start at different times. This is a multi kind of step process. And I want to highlight just some of the examples of the tasks that get transitioned from parent to child. Again, this is an example of breaking a big mountain down into a bunch of little hills on a to-do list, thinking about, how do I make appointments, attending them, keeping a list of them, who contacts insurance, right? That's likely something that a parent is doing for quite a bit longer before the child takes over. Describing that condition to others, right? When somebody asks, why weren't you at school today? Who says like, oh, I had to go get my imaging, right? That's a process or a small task that we can transition as well. It's important to talk through who's doing what and what kind of system works for you. We typically, in teaching, we talk about an I do, we do, you do strategy. So in their early teens, they may watch you do this. In their late teens, you may do it together. And then they'll do it on their own, knowing that you're there to support them. I want to just show one brief example. This is the von Hippel-Lindau slides. So here we see right around age 10, the adolescent joins the result discussion. So if the doctor calls or we pull up the results, it's something we do together. Around age 15, the adolescent and parent develop a system together of how to keep track. And we start to see the adolescent answer the doctor's questions first, and then have the parents add on anything that's missing, because we know teenagers don't always share all the information. At age 18, it's important for them to discuss scheduling and decide who's going to be in charge. Is the adolescent going to take over, or are they going to sign a release so that the parent can still be involved, moving them through emerging adulthood, that 18 to 25, to really be at a place that they're able to walk through this process themselves. Again, this is a partnership, and so it's really important you are able to work with the care team and your child and you to help walk through this process. I'm going to walk through just a few quick screening family questions. One comment that we heard a lot was, okay, I lost my partner to this condition. How do I maintain normalcy while dealing with the stress of my children's risk? And I think that this really goes back to how we deal with other stressors. Stress related to our children, stress related to other areas. What is a similar scenario that you've been in that we can walk through this process? I also think it's important to note that as they're growing up, right, they'll know that somebody that they were close to isn't here because of this condition. And so helping them understand the importance of screening to make sure that that kind of doesn't occur with them is one way to approach it, and really help the child frame it in a way of being proactive rather than reactive. Now in the digital age, everybody has advice for the family. And so oftentimes people ask, how do I support someone with a mutation when that happens? And I'd really direct you back to a care team. The internet can tell you many things, and there are great resources we direct our patients to, like Pheo Para Alliance. But it's also important to have somebody to help weed out that noise. And so finding somebody that you trust and really being a support rather than necessarily an advice giver for the members of your family is another strategy to think about it, because it's hard. Excuse me. We don't listen, quite as often as we're used to, because we're so able now to go get advice and find what's on the internet, that sometimes just being a listening ear can be really great. And lastly, I think it's totally normal to think about fear of the unknown and uncertainty that comes with screening. In these scenarios, again, thinking about how you've handled fear and uncertainty in the past can be really important in thinking about how to manage this. I'm just going to include a quick bonus slide. This is a double-edged sword, and I want to be really transparent about this. I sometimes see support groups and other conversations where people say, hey, there was a Pheo on this episode of a medical TV show. It's us. Excuse me. And I want to be clear that this can be a really bonding and exciting experience for some people. There are also other people out there that might watch this and see some of the sensationalized aspects of medical TV and feel like that is their future. And so if you are somebody who this can help relate, please take a look at the television shows that I have thus far found. If you have others to add to the list, please let me know. But if you are somebody who, can feel overwhelmed by the sensationalized aspect of medical TV, I would encourage you to just kind of think twice before you head down this road. But some people may say, oh man, this might be a great way to show my child. And again, I'd encourage you to just watch these in advance and really think about you and your child to see if that would be a good fit. For some it is, and for others it's not. So you likely have more questions. We are going to open this up for Q&A in just a second. I included just a long list. I referenced part 1 a number of times. If you have other questions and they fall into this part, I encourage you to go back and look at part 1, or I'll provide my contact. I'm always happy to chat. And again, just highlighting that the Pheo Para Alliance is an incredible resource. I'm grateful that they had me today, and also encourage everybody to just check out what they have to offer. Before we get to Q&A, I just want to highlight, I'm more than happy to answer questions at any time. My email address is located here. And as Catherine noted, I focus on paraganglioma cancer genetics as well as prostate cancer genetics. So if you are interested in Pheo, para, or prostate-related items, feel free to find me on Twitter as well. And with that, we can open it up to questions.
All right. So for our first question, is the recommendation that everyone who's diagnosed with Pheo Para to have the genetic testing done?
Yes. Yep. So typically when we think about genetic testing for Pheo, or for kind of any kind of hereditary cancer genetics, we think that the rate of about 40% of Pheo Para being associated with a genetic mutation is high enough that all diagnoses of Pheo Para should get genetic testing.
All right. The next question. All right. What advice can you give to significant others if someone has a genetic mutation? How can I best support them?
Yeah. So in genetics, we sometimes think about it is sometimes harder to be somebody not with a mutation than it is to be somebody with, because often there's family members that they can connect with, and there's almost a connection that's built. And especially when we're the significant other, asking ourselves, how do we be supportive and how do we help? And I think the question really stems from, what does your partner need? And really asking them, is it coming with them to their imaging scans because those raise kind of stress and anxiety for them? Is it coming to the doctor's appointment? Is it being a part of that process in a different way, or attending, Pheo webinars? What does that really look like? And so I think that this is a question to really ask your partner and really have some ideas, but also know that the best way to support them is probably just in listening and doing what you're doing and asking the question to them.
Thanks.
Yeah.
Sorry, I think I'm just having a delay on the questions here.
No worries.
Okay, the next question is, I have an SDHB VUS mutation. What are the odds of offspring carrying that? Are SDHB VU mutations common? Are they usually benign?
Yeah, that's a great question. So the frequency of getting a variant of uncertain significance varies by lab and by gene. And so I won't go into the details, but we know that typically up to about 20+% can have variants of uncertain significance in their test results. And this is where we get back to the idea that most variants that we find in our body are negative or just benign changes that make us who we are. And so typically we treat them as negative. Technically, we would presume that your children would have a 50-50 chance of also having that uncertain change. But when we have an uncertain result, we don't necessarily know if that's related to a Pheo diagnosis, or again, if it's just a benign change that you and your family have. And so we don't necessarily make any changes based on it, even though other family members could have it, because again, most of the time these become negative. The lab does reclassify uncertain results over time. And so if at some point they felt like it was connected to that Pheo diagnosis, which is a very small % of the time that happens, then they would contact your provider who ordered the test, and they could help make those changes. But for now, we don't do testing for uncertain results in family, and we don't change screening for them.
Thanks. The next question is actually about family planning. But this question is it possible to take a sample of sperm or egg for a person that has a mutation and choose one without the mutation in order to plan for a baby?
Yes, definitely. So that is what we call preimplantation genetic diagnosis. Essentially, couples go through an in vitro fertilization process, and then the embryos are tested to see if they have the mutation or not. And then only the embryos that do not have the mutation are implanted. And so this is something I would encourage you to reach out to. Either a prenatal genetic counselor would be a good option for this, or often there are reproductive clinics or reproductive endocrinology clinics, and they typically can help facilitate this process if that's something you're interested in. And if you're not sure how to contact one of those, whoever helped kind of do your genetic testing should be able to help find a resource for you in that realm.
Thank you. And the next question actually concerns dealing with diagnosis or the genetic mutation in a mental illness. How much should you tell a teenager with depression if a mutation runs in your family? How do you handle that?
Yeah, that's a great question. When we have scenarios in our clinic when a child kind of needs to learn this news, and we're going to walk through this, and there are some other kind of mental health underlying conditions, then we typically include our high-risk psychologist who's a part of our clinic. Her role is to really help facilitate and be a resource as we learn to adapt and cope. But I think you bring up a great question, which is how much to tell them. And I think that's really a personal decision. I'm guessing that there are other pieces of bad news, and I hate to reference 2020. I hope, in a few years, people are still watching this webinar and we look back on 2020 as, a blip on the screen. But I think it's important to note that we've dealt with tough news in the last year. We've all had our lives changed in one way, shape, or form by what's happened in the last year. And those are events that can impact depression, just like a new genetic diagnosis. And so leveraging some of your experiences in the last year can really help think about what to share. How much is too much? How little is too little? And what is the right amount to share with your child? And whoever is on their care team potentially helping kind of monitor and manage their depression may also be a really good resource to talk with them and mention, we have more bad news. I say more, mostly referencing kind of the last year. And again, not because I think that having a genetic mutation is bad news, but I think it can be tough news to hear. And so really talking with them, okay, we have news to share. How do I go about doing that?
All right. The next question is, our son is 24. He has difficulty scheduling his annual test by himself. I'm having a little trouble balancing being a protective parent and making sure he gets the scans that he needs on time. Would you have any advice for that?
Yes, we have a lot of these scenarios because I think, especially when our child is still on our insurance and they're walking through this process, it can feel like we want to stay kind of attached. I think the question would probably be, how can the care team help? And honestly, one of the things that I've seen some of our families do is when they have kids that are kind of in their early to mid 20s struggling with that process, they might help make the appointment and make sure the child kind of goes to the appointment. But the kind of adult, right, at 24, the adult goes themselves. And that really forces them, they have to answer their own questions. They have to know what's next. They have to schedule these processes. And this can be one way where you're still helping with that process, but in essence, kind of really empowering them to be autonomous in some realms that may likely help them gather some other tasks to take on their own. So that might be one strategy. But it really differs and varies. And I think there also gets to be an age to some extent that there's only so much we can do, very much like our siblings and our other family who don't want to get genetic testing. If we try this and we give them opportunities to be autonomous and it's still not working, then it's really time to have a conversation about, do they want you to keep helping? Is it better to just let them go? And how you really feel about where they're at and their kind of capacity to be able to take that on.
Okay, the next one is, our son has an SDHD, an inherited gene defect from his dad. If he were to get the tumor, will his symptoms be worse? Would he be likely to get a tumor?
Yeah, that's a great question. So when somebody has an SDHD mutation that they inherited from their dad, they would be more likely to get a tumor compared to somebody who inherits an SDHD mutation from their mom, where there are very limited reports of Pheo being diagnosed. However, when we think about symptoms and impact, I don't believe that there is any evidence or data to suggest that the symptoms would be worse or that the tumors would be more or less kind of based on age of diagnosis and how many tumors there would be. So the risk would be what we typically find to be associated with an SDHD mutation, not necessarily more or less because it came from dad and dad has a history of tumors. In general, we know that when an individual has an SDHD mutation from their dad, they have the highest risk for Pheo compared to the other SDH and many of the other genes. And so it's really imperative that we're screening everybody who has one of these mutations for Pheo and especially for SDHD because the risk is higher than the other genes, though there are a number of people with SDHD and other mutations who never develop Pheo in their life.
Thank you. The next question is about SDHA. This person says that they have an SDHA gene defect, and it doesn't seem like they're getting any information and no one knows about it. What could you say about an SDHA gene defect?
Yeah, SDHA is probably the gene that we will hopefully learn the most about in the next 5, 10 plus years. And the reason for that is it's one of the newer genes that we have learned to be associated with Pheo, but also we believe that the risk for tumor is quite low. So if somebody has an SDHA mutation, depending on the research, the lifetime risk for developing one of those tumors could be as low as about 2%, although other studies show anywhere from about 5 to 15 to 20%. But still, that means the majority of people with an SDHA mutation will not develop Pheo. And if it's closer to 2%, if that risk is truly that low, then most people, right, over 95% of people with SDHA may not develop these tumors. And so as a result, we don't know as much about it because we don't always find people with this genetic change. We are starting to find more. But honestly, as we find more people with SDHA mutations, it's in people who often have genetic testing for something else. And then we find this SDHA mutation almost by chance. And so this has really kind of thrown us as researchers into a space that we need to learn more. And we need to know how to manage it and then how to best kind of work with others. We know that the risk for parapheo is nowhere near, what the risk if you have an SDHD mutation is. And right now we screen them the same. And so as we continue to get more data and more information and more background, that should all really help us move the needle forward on SDHA. For now, we do recommend that people with an SDHA mutation undergo imaging and biochemical testing or blood work, just like the other SDH genes.
Thanks. The next one is, do you have any advice for dealing with the frustration of the sibling who has an SDH mutation and they have symptoms? This person's want to nag them, but they have a concern. How would you deal with that?
Yeah, the symptoms of Pheo can be really challenging because they can present as so many other things. As many of you know, right, your experiences can be variable, and a lot of them are kind of non-specific, whether it's a headache or heart racing or things like that, that can happen to all of us in an acute sense. And oftentimes for people with Pheo, those symptoms are a little bit longer lasting. So it can be easy, you can imagine, as a family member who has a symptom here or there, they might chalk it up more to kind of normal versus maybe something that's become chronic and could be indicative of a Pheo. And especially to your point, we don't want to nag because that can almost have the reverse effect that we want it to. I think the best thing we can do is continue to speak about our experiences. So as you get your screening, as you have your follow-ups, as you're on these webinars, right? In conversation, if things come up like, hey, what'd you do this week? I listened to a webinar on SDH and the Pheo, right? The more we talk about it in kind of a non-judgmental, non-naggy way, the more that we provide our family members with the information they need to make the best decision for themselves. And I know that the suggestion I'm making is very hard. It is very challenging to watch a family member go through something and watch them go through the decision-making process and not make the decision that you would have made. And so really kind of finding a way to say, okay, I've done the best I can. I've given them the information and I'm going to keep it on their radar, right, as things arise and as it's relevant. But the best thing I can do is to be a support and help that person with whatever they need or whatever they choose to do, even though that's a really hard thing to do.
All right, I think we have time for another question or two. Okay, this next one is, I come from a very large family. I tested negative for all the mutations, but I know it runs in my family. Many of the other family members cannot afford to be tested. Do you have any thoughts on that?
Yeah, Definitely. So depending on, it sounds like if someone's come from a large family, I'm not sure the timing of that diagnosis, but what I will say is that in the last few years, the genetic testing labs have really moved leaps and bounds in their financial assistance and accessibility. And so many of our patients right now, I think the last statistic is like over 75% of our patients don't pay out of pocket, and over 90% of them pay $100 or less. And I want to be clear that in that 75% are not just people who have insurance, but also our patients who have lower income or are uninsured. The financial assistance programs within the labs have, really become such that testing can be accessible and affordable to many. And I think talking with kind of whoever your provider was or others about options and what that might look like may help them kind of get in to see people. There are some genetic counseling clinics that don't bill for their services. That may be a resource. And so those opportunities are out there. The other thing is that if the family members see any kind of healthcare provider, this might be a great example, given that there are so many financial assistance options through the labs. If they have a primary care doc, meeting with that doctor to help facilitate the testing can be one option. Typically, we recommend that there's some kind of genetics consult. But in general, it's also okay if they just get the testing because that's what we need to know, and this is what we can make work. So I think there's an aspect of potentially one, having your relatives check back in because labs have extended their policies. And then two, thinking about if there are other providers that may be able to help facilitate this to ensure that testing gets done. And then again, connecting that doctor with either your team or somebody. I speak with primary care docs all over the Mountain West who, their family member can't get to us and they want to help order the testing. And then we help kind of the provider make that happen and make sure they have the resources they need, if the patient isn't able to come see us.
Great, thank you. One last thing. Do you have a last message for anyone in our community that is listening that does have a genetic mutation that runs in their family? Just kind of a message moving forward on that. The last thoughts.
Yes. Yeah. So I think for anybody who is watching or listening and family, you have a mutation or somebody else does, genetic testing is beneficial. And at the same time, it's not nearly as helpful if we're not screening for it. And so helping a family member through the genetic testing process is imperative, and equally imperative as helping them get screening set up and finding the resources to help them, identify tumors early. And ultimately, genetic mutations are a family affair, and families have lots of different dynamics. And so taking what works best for you and adapting it to the way in which your family can move forward to be proactive is kind of the best way to move forward, and utilizing your care teams and Pheo Alliance as a resource to help.
Well, thank you. I think that wraps up the time that we have for today. I just want to say, Samantha, thank you for your time and your dedication to our patient community. It's very helpful. And I also want to take a second to say a special thank you again to Progenics for making this webinar possible. This will also be available if you want to replay or you want to share it to somebody else in a few days on both YouTube and through the Pheo website. If this information has been useful to you, then please consider making a donation to the Pheo Alliance. You can donate at pheopera.org/donate. And thank you again to everybody who attended today. And please remember that we are Pheo Fearless. Thank you.